David wanted me to talk about pediatric trauma. So I guess I'm just going to try and recap some of the key highlights. I suppose you all know it, hopefully. And if not, you could possibly learn something out of this. So if we think about the global burden of pediatric trauma, we do know that it still remains #1 killer in children more than 5 years of age. And there are clearly far greater number of deaths than HIV, AIDS, TB, malaria combined together, purely due to traumatic injuries. And that's kind of the ballpark figure of more than 5 million deaths per year. So this is the data from an international study about 3-4 years back. And unfortunately, there's still about a quarter of these which happen due to unintentional injuries. And this is, if you try and imagine, this is the data that is available. There's probably a large proportion of these which are not reported or not captured. 95% of these still occur in low and middle income countries. So being in the UK, we are lucky because we don't see as many deaths. And 40, although, I mean, having said that, 40% of actual mortality in high income countries still is related to trauma. So that still forms a large proportion of what we would see. And what's even more important to acknowledge is more than 10 times of the mortality are non-fatal injuries. So the proportion that we would see, because some of these would be pre-hospital before they arrive here, and possibly those who die, yes, we can make a difference, but then there is a larger proportion who would need rehabilitation and ongoing morbidities. So in the UK, we launched what are called the trauma networks, which I'm sure now everybody is aware of and very familiar with. And they started getting embedded in the system about 2009, 2010, when there was a recognition after the NC-POD inquiry that we still had much worse outcomes in terms of patients with traumatic injuries in comparison to some of the other high-income countries. And the idea is to have a major trauma center, a hub and spoke model. So every region's got a major trauma center. And then there are spokes, which are the trauma units. So the major trauma centers concentrate all the expertise. And the trauma units stabilize and then transfer the patients over to the major trauma center. And this was a paper few years back, reviewing what the impact of trauma networks has been within UK, and Chris Moran, who was then the National Clinical Director for Major Trauma, published this study and looking at outcomes between 2008 to 2017. And as you can see, this is where 2010, 2011 is when the trauma systems were initiated, and clearly the outcome and the survival from major trauma is already showing an improvement up until 2017. And I think we've seen less of the data coming out post-pandemic because the pandemic changed the entire demographics and the landscape of what we saw and what we did not. This is some of the data, similar data in the pediatric world, looking at the TARN database. This is published in 2019, looking at 7 years worth of data. And we sort of almost intuitively know what this is like. We know that head injuries are still the commonest injuries. When we're looking at major trauma patients, although when we talk about trauma as a whole, limb injuries probably surpass the head injuries. And then when you look at the age categories, clearly as the head injuries have two peaks in the early age and then at the upper end of our age spectrum. And that's when adolescents start having risk-taking behaviors. And the younger age group, unfortunately, we see a major proportion of children who present with non-accidental injuries. To put it further in context, when we look at ISS greater than 9, and for you, Leah, I'm sorry I missed your name for this. For you, I'll come back to how we score the trauma. But essentially, we code anything greater than 9 injury severity score as major trauma. If you look at that, the proportion of children that we would see in UK in comparison to adults is still very small, very, very small. This is just a latest work that NHSC has done within our region, east of England, and this is mainly to see whether we need a second major trauma center or not, given that Addenbrooke's reached its capacity in 2017, 2018. And this is not to do with pediatric trauma per se. We've got an increasing elderly population, and as this data reflects, the median age of major trauma we've seen in east of England is 72 years old, and falls as the commonest mechanism of injury, which actually means that we need to make more provision. So it's a very interesting document. I haven't put any more details just because it's mainly adult focused data. This is what we look like in pediatrics. So only 3% of total east of England pediatric trauma patients, as we saw in the national figure, reflects here as well, are the pediatric trauma patients. And then this is a slide I stole from Ruddy. He's sitting right there. And if you look at the national picture of pediatric ICU admissions, trauma as a primary diagnostic group is only 2%. So just to highlight, it's a rare disease, it's a severe disease, and that's why it's very important for us to practice, have some knowledge so that when it comes, we're not completely thrown out of our comfort zone. And I'm talking a lot about the data, but this is just to highlight, like, what is happening nationally. TAN has now been taken off because of some confidentiality data breach issue. So they're creating a new national database, which should hopefully be up and running sometime this year, which will collect the data. So TAN is, for the medical students, it's Trauma Audit and Research Network. It was a national body which collected data on every trauma patient. And there's certain criteria beyond which the patients would be eligible for TAN entry. And any patient who hit the injury severity criteria, as well as hospital admission for a certain number of days, would then be captured by this data, which became a very useful resource for providing service, understanding what is required, which patient group we see, what is the commonest mechanism of injury, what the outcomes were, etc. And also form the part of what is called as best practice tariff and the benchmarking between different trauma networks and trauma centers. This was a national child mortality database, which has become a little bit more embedded since they started using the child death overview review panels, and they produced a traumatic incident-related deaths in children and young people in 23, so fairly recent. And when we look at the pediatric data figures here, I mean, we're clearly looking at those who died, and high energy trauma is what we know is the major killer. So clearly 211 vehicle collisions followed by violence and maltreatment. So these are the two major groups. Of course, a lot of focus going into drowning, which we see more in the summer, and then a little bit of everything and everything else. As a region in east of England, we see very minimal penetrating trauma, and even less so in pediatric populations. So we've been lucky so far that we don't see this left, right, and center, as probably some of the London centers or Nottingham might see. And this is the last pediatric specific report that was published from TAN in 2019-2020, and they've been dismantled as of last year. So out of total 4 million ED attendances by children, the numbers that actually made into TAN database was less than 5,000. And out of this, again, like, minimal 1 to 8, which would of course not be the population that would fulfill the TAN criteria, but 9 to 15 and more than 15, the largest proportion of patients. And as I was talking about the age categories, under ones, and then of course the adolescent age group as they become more and more independent and start taking risks. And if we try to dig deeper into the under one age group, as you can see, the larger proportion is under 4 months of age. And unfortunately, this is the non-accidental injury growth. We do know that babies cry more around 3 to 4 months of age, and this is the population, and the parents are being given now the leaflet and what is called described as ICON. So this is just trying to give them tips about how to handle a crying baby rather than shaking and anger management. And they're trying to address that by capturing the antenatal clinics, capturing the GP surgeries, as well as these what are these groups called when the parents link up because they were together in the antenatal classes, etc. And we are hoping that that would reduce the number of non-accidental injuries because it's essentially preventable and has high morbidities. And then again, looking at what is the major injury causing significant trauma, very obvious for pediatric age group is head injuries. And why so? Because we've got a big head, which is nearly 1/4 of the body when you are under one, whilst in an adult it's about 10 to 15%. So, and it's heavy, so the fulcrum and the energy transmission is much greater. And this is the injury mechanism by age. So this green is the non-accidental injuries. And then, of course, as they grow older and more independent, you see an increasing blue, which is the road traffic collisions. This is just to highlight the different major trauma centers that are available in the UK, and there are 4 standalone children's MTCs, but majority are combined like us here, where we see both pediatric and adult trauma patients. And this is us as East of England. So we sit in the center here, and then there are trauma units spread all over the region. And these lines, the brown line inside is what would take 45 minutes in the working hours, in the peak hour traffic, from the area of injury, scene of accident to the major trauma center. And then the green is what would be the out of hours, 45 minutes journey time. And that defines as to what the initial destination would be for a patient who sustains trauma in any part of this region. And they use this as a rough marker of whether it would be safer and timely to bypass a trauma unit and come directly into MTC, or otherwise. It will also depend upon whether it's air or land transfer and the weather conditions, etc. So lots to take into account, because out of hours we do not have a helipad on site, which is safe. So they land at Marshall, and then the journey from Marshall's into here in itself takes good half an hour. So whether then the land transfer is safer and easier. This is how we are structured. So there's a trauma network office. And then within Addenbrooke's, we have a network coordination service. So network coordination service is staffed by an ED physician 24/7. And they get a heads up about a trauma as soon as the trauma happens at the scene of accident. So as soon as the 999 call goes out, they get to know that there's a trauma at a certain region, or and then they can coordinate the care of that patient. They can advise in terms of the destination, the first destination, where should the patient go, and if there is a requirement to conference and experts, they can do that. And then they will also facilitate a secondary transfer from wherever the patient has gone first. They also have the authority to accept a patient without finding a bed in Addenbrooke's, because we are commissioned to look after all level 3 trauma patients. So for example, if somebody has a head injury and has time critical extradural that needs evacuating, if we don't have a bed, they'll still say yes, and the patient would come here, get the hematoma evacuated, and then we will look at the next step for this patient. Either we create an ICU bed, or we try to look for an ICU bed somewhere else. So those kind of conversations happen. The network transfer services existed in the beginning, but then they disappeared because they were charity funded. But now we have an adult critical care transfer team. But essentially all the time critical would be transferred by the local teams. And the pre-hospital teams would help as well. And then, of course, the trauma units and the major trauma center alongside the rehab services is how it all functions. Interestingly, this is the national data, and we've been an outlier in east of England because we are such a wide geographical area in terms of where an injured child would come to. But nationally, majority of injured children still present to their local hospitals. And they are secondary transfers. Although nationally there is a drive that they should potentially bypass the trauma units and come directly to MTC, because as we saw, it's a rare significant disease, and the trauma units would not be used to seeing a significantly injured child and not have the expertise to deal with this. To improve the outcome, if they came directly to a tertiary center which had all the expertise, their outcome could be better. But clearly the geography plays a role. And secondly, also very important, the non-accidental injuries do not present as trauma, and they would present to their local hospitals as something, and then trauma comes later. So this is an ongoing debate. We've already seen that. And then we've got these things to try and improve the care. So there's a trauma team essentials course, which the East of England Trauma Network runs. We have got a tempo manual, which gives you some guidance as to how these patients should be managed, who to call when you need support. And then, of course, we've got a pediatric specific leaflet and team here. So sorry, lots about the region and what it actually means. But coming to the actual trauma, we do know when it comes to children, the high proportion of deaths happen in the ED or on arrival. And early deaths usually happen in older patients, those who present with penetrating injuries and those who have low heart rates and low blood pressure. And then, of course, when we're looking at first 24 hours, those who have mainly chest trauma, and then late are related to those who've got significant blood transfusions, raised ICPs, etc. So significant head injuries and organ failure related to that. I think most important on this slide to acknowledge is that nearly 30% of those who will come to a hospital are preventable with rapid identification and early aggressive therapy, and that's where our role comes in, and that's what we need to focus on. And although this is an old data in comparison to adults, there is more blunt trauma in children and more bradycardia as we would see it. Never happened. Right, so a little bit about scoring system. I just realized, I'm sorry for both of you, because it would have been easier for you to understand what I've spoken so far if I'd spoken about the scoring systems earlier. But basically, there are two main scoring methods, physiological and anatomical. And then there are some that use combined methods. The AIS and the ISS have shown so far are both anatomical models. So AIS stands for abbreviated injury score, and ISS stands for injury severity score. And AIS is given to one specific organ system, and then the injury severity score is derived by square of the two most severely injured organs in the body. And the scoring ranges from 1 to 75 when it comes to ISS, and each organ system is graded between 1 to 6. The severe injuries are usually defined as those which are AIS greater than 3. That's what one of the slides showed earlier on. And when we try to square them and then make a total sum, which is defined as injury severity score, the way that is used to define the severity of trauma is, so mild trauma is 1 to 8. Moderate is 9 to 15, and then major is more than 15. But nationally, the parameters that are used to benchmark different MTCs, ISS greater than 9 is considered as major trauma. The disadvantage of anatomical scoring method is it's done only after you've completely imaged a patient. So it is not something you can do as the patient arrives at the front door. What do I need at that time is more about the physiological instability that patient would have. And that's probably where there's some work which has been done, not very well published yet, but possibly because for children, all the major trauma would end up in PICU/HDU. What we found is that PIM, so PICANET uses PIM, which is the pediatric index of mortality, which is the score we use for all critically ill children. That tends to perform better at the lower age groups when we look at trauma patients, while the injury severity scores perform better at the upper end of the age group. And if you think about it, it makes perfect sense because PIM mainly is a physiology-based score. And as we know, the younger a child is, the more the physiological instability defines how sick they would be. In comparison to an older patient, for example, a 15-year-old adolescent, they would be like an adult. So what would define their outcome or the severity of the injury is the number of organs they have injured and the severity of particular injury. But nationally and internationally, the anatomical scoring method, so AIS and ISSR is what is used universally more than the physiological methods. Physiological scoring methods are more used as triage tools. So for example, you've got a mass casualty, there you would use a physiological scoring system. And that is useful to define which patient should get urgent attention, where they should move, and then they define it as P1, P2, P3, depending on what you're doing. So these are some of the physiological scoring methods that are used in pediatrics, revised trauma score and pediatric trauma score. I won't go into the details of these, just to highlight that these scores exist, but we have not used them as regularly as the other one. And this is what we would use in a mass casualty event. So where you define patients as P1, P2, P3, and then they have a card. So they'll put a red card or a green card and a black card, depending on what the patient needs. So priority 1, of course, needs urgent attention. Priority 3 are walking, so they don't need any attention and they can be left for later. And then priority 2 are those who would need attention at some stage. So they need to define how many patients. And then the way they would use the command in the hospital, we've got this silver gold command, basically. And then the way the conversations, the communication would happen with the bases, we've got 2P2, 5P1, so that you know what kind of resource and the teams they would require for that patient. And this is just how the triaging is done and the priorities are given. Outside a mass casualty event, as I said, we'd use physiological markers more than anatomical. Clearly, anatomical is important, but in the immediacy of the trauma management at the scene, this is the scoring that the East of England pre-hospital teams will majorly use. There's some difference in what different teams use, and there's still ongoing work in trying to unify a simpler system. But basically, the way they define a patient is called a candidate major trauma patient, because as we know, we can't call them a major trauma till they have been imaged, until we know what is fractured and which organ is injured. So they talk about a sustained respiratory rate below 10 or above 29, and then use age-appropriate values for pediatrics. Population, sustained blood pressure. So basically, these are all physiological markers, right? The respiration, the hemodynamic instability, and the neurology is what defines what their initial destination would be. And then this then helps to decide, depending on those squiggly lines I showed on our East of England map, whether the patient goes to a trauma unit or ends up coming to trauma center. And I think these decisions are important because if somebody is hemodynamically very unstable and you think they would need blood products, or maybe they've got a bleeder somewhere which can be easily accessed by a surgical team, then it is safer to go to the nearest center because they can get blood products there. And fairly recently, majority of the pre-hospital teams did not carry blood, especially in our region. In London, they did. The HEMS team did. And I know some of our East of England pre-hospital providers are now starting to carry blood with them. And this is just how the abbreviated injury score, for example, looks like. So 1 to 6 defined as minor, moderate, severe, serious, severe, critical, and then maximum. So this is how it would look like. And this is just a random patient, cooked up patient. So minor is superficial laceration, moderate is a fractured sternum, serious is open fracture of humerus, severe would be perforated trachea, critical is ruptured liver with tissue loss, and maximum is total severance of aorta. And similarly, this is how we would score it. Right. So I've talked a little bit about this. I very briefly spoke about the relatively large head in comparison to the body and the chances of traumatic hit in a child. And then, of course, the dynamics of injury transfer are very different in a pediatric skull, as you'd imagine, because it's not fully ossified. There are open sutures and fontanelles, so it probably tends to absorb energy early and can cause significant amount of bleeding in an infant, which can cause shock. You'll only see shock in relation to head trauma only in under 3 months old, because otherwise the fixed cavity of the skull is in itself good to cause tamponade effect and stop bleeding. And I think the other important consideration is the spine. So the fulcrum the cervical flexion fulcrum is much higher in infants, and it grows quarterly as you grow older. So all the cervical injuries and the spinal injuries are less frequent in children. When they tend to happen in younger children, tend to happen much higher in comparison to the older children. And because of the poor ossification, the so-called scevora, which is spinal cord injury without radiological abnormality, is more of a pediatric phenomenon than adult phenomenon. And the nomenclature of that is now being questioned, because we do have radiological abnormality, not on a CT scan, but on an MRI. So should we really be calling it spinal cord injury without radiological abnormality? And then, of course, we see a lot more children with non-accidental injury, as I showed, in under 1, especially those up to 4 months of age. It's a higher proportion of our patients. And I think this slide shows what impact suspected child abuse would have in comparison to accidental trauma. So the outcomes are much worse, and the morbidity that these unfortunate children sustain is much greater than what you could get, because it's not just a one-off trauma, it's a sustained trauma. And then, of course, the anatomical and physiological considerations keep going, because they've got narrow, short airways. Small changes in caliber means we have to be aggressive. And I think it is important to remember children get early hypoxia, but late hypotension. So we need to be really aggressive in terms of airway management, and consider whether or not they would be losing blood somewhere, because they may not become hypertensive till much later. And because of the easily compressible ribs, they may not have rib fractures as commonly as adults, but they do have pulmonary contusions a lot more frequently. And when we see rib fractures, we only see them either in high energy motor vehicle collisions or in non-accidental injuries. And of course, because of the poor ossification, there is less abdominal organ protection. And we do see, because the proportionate size of the abdominal organs is larger and the musculature is less well developed. So we do see large organ injuries in pediatric population. However, great vessel and cardiac injuries are rare in pediatrics. This is just what I was just saying, so I'll rush through them. And then, of course, the key metabolic differences in pediatric population. So much higher metabolic rates, nearly twice as rapid oxygen consumption in a young infant in comparison to adults. Increased blood flow, more frequent feeds, and poor glucose reserves mean that we need to be fairly aggressive when we're managing these patients. As I said, late hypotension, early hypoxia, if you remember that, we'd hopefully be switched on to address those two bits. And of course, the fact that if we look at the early recovery children, do sometimes surprise us because their early recovery can be good. But then we forget that the long-term impact on their eventual outcome could be much worse because they don't need to get back to year 5 if that's where they had a head injury. They still have to grow all the way to higher executive functioning up until 25, and that can be severely hampered. Sorry, stop me. Am I going too fast? No, it's yeah. So that's kind of a little bit more about the background and the theory and etc. etc. But how do we manage these patients? Well, the good news is it's the same as you'd manage in adults or as you'd manage any other sick child. And I think we are both equally guilty whether you come from adult background or you come from pediatric background, because either end of the specialty feels uncomfortable dealing with pediatric trauma because you're not familiar with children and pediatricians are not familiar with trauma. But then it's just like a sick child, right? With just a few additional thoughts, because we're dealing with trauma, especially if it is high energy, we need to think about cervical spine and we need to think about catastrophic hemorrhage, which are 2 additional points to any other APLS algorithm that you would be applying to a sick child of any other description. As I said, obstructed airway and shock are preventable causes of death. So early aggressive management of airway. And then, of course, the history of accident is critical in determining the intervention plan. As it goes without saying, reassess, reassess, reassess. And then support for the families, because not infrequently you'll have multiple members of the family affected, and that requires a huge amount of support. We've had some really sad emotional cases in the recent past where we've had more than one victim from a house fire, or a mom who's severely head injured in NCCU whilst the child was here and dad was on JVF. So it's can be a fairly challenging situation to deal with. So C-spine collars, I think it's an area of slight controversy, and that mainly came from the fact that we didn't have right-sized collars and we were probably causing more harm. So APLS changed its guidelines probably around 2014, 2015 to say don't use C-spine collars. And the messaging went out there that don't protect the C-spine, which was completely wrong, because I think we do not want to use ill-fitting collars, but equally we want to protect C-spines for those children who cannot protect themselves. Now we have much better sized collars, and collars not the only way to protect a C-spine. So I think the rule of thumb is all children with altered level of consciousness. So I would say if a child can't protect their own C-spine, protect it for them, right? That's our duty, unless we've proven that they do not have any underlying disease. And then, of course, those in which we think that the mechanism of injury is significant and it can affect the spine. And fairly obvious if there are any signs and symptoms consistent with spinal cord injuries. So we can use manual inline mobilization. We can use blocks and tapes when they are intubated and ventilated, sedated. This is just some work we did here, looking at 5 years worth of our patient data. And what's telling out of this is that the reported incidence of spinal cord injuries, or spinal injuries, I should say, is 2% in pediatric population. I think we also need to be mindful that this might be skewed because we're looking at MTC, we're looking at all patients who are admitted from across the region, but we saw 12% of children who had spinal injuries, and 86% of these had polytrauma. Again, the age peaks of infancy and adolescence, and then more bony injuries in the C-spine, followed by thoracic or lumbar. So, as I said, please do protect it for a child if they can't protect it themselves. Tempo gives you some guidelines as to what you could do, what the best way to protect these C-spines. As I said, early hypoxia, so consideration for semi-elective intubation, consideration for the right-sized ET tubes, etc. And then, of course, preparation for decompensation, because that's not infrequent. As I've already, I think I will not go into the details of the differences in airways as well as the different sizes of blades, but that complicates things, especially for pre-hospital teams, because they will not be dealing with pediatric population that frequently, and our sizes are from 2 to 120 kilos. So how much preparation or experience can you have in intubating each one of these? This is a very interesting paper in looking at the tracheal tube misplacement after emergency intubation in pediatric trauma patients. And it's quite significant, actually. Again, it does bring it to question, like, we talk about early aggressive airway control. How would you make it safe, and whether it is safer to bring a patient across unintubated or have a misplaced ETT. And we do have some safeguards in place, like using ETCO2 measurement, doing some sim training. How effective that is in real life can be a challenge, because if we look at our figures, we probably, given the shift pattern, etc., even the busiest pre-hospital teams would probably be dealing with a severely injured child maybe once every year or twice a year at the most. So just to remember that we know that we are pediatricians, and that's where the role of people like us comes. We are familiar with the physiology. We know what is normal and what is not normal for a child, and that can be sometimes missed in the heat of the moment by teams who are not used to dealing with children. Like once I was there, and I still carry the guilt. There was a 9-month-old child who had been extracted from a car, and they alerted us. There was a massive hemorrhage protocol activated before the team arrived. And then they delivered the child, and even before I could turn around, they had the whole Belmont set up, and then child had the blood transfusion, and the paramedic turned around and said the systolic blood pressure is 90. It's not for a 9-month-old, and the child had a full blood transfusion, and hemoglobin was 15. They were worried because they didn't. They were not aware of the physiology, and they were clearly doing their bet. And they thought this child was in peri-arrest because the end-tidal trace was inconsistent, but the end-tidal trace was inconsistent because the ET tube was sitting somewhere around the vocal cords, was not really through the cords. So another example of a misplaced ET, which then led to an unnecessary treatment, but can be potentially very dangerous in this situation. So just to highlight how our respiratory and heart rate values, as well as the blood pressure changes as the child grows up. And then, of course, this is what we see sometimes. I was involved with this because it became a governance issue. They were bringing a child, a 4-year-old child with traumatic brain injury, who'd been intubated, and then they were trying to manage the end-tidal and kept cranking up the ventilator because they couldn't get the end-tidals to come within normal limits, up and up and up and up, till the child arrived here. And what we did was disconnected a very long dead space, and the end-tidal came right in. So, just to be aware that how much difference it can make to a small child, especially in that setting where I think I'm not going to go into the details of this. So I think just wanted to talk briefly about the shock management and how it would differ from any other shock management in a child, which was non-trauma related. So what do you think? Is hypotensive resuscitation a concept in pediatric trauma? The problem with hypotensive resuscitation as a concept or as a terminology in pediatrics, one, there is no data or evidence to support it. 2, we are very scared because majority of our children have head injury. So you know what we want when child's got head injury, we want the brain to be perfused adequately. So that's why it's not advocated in pediatric population to say hypotensive resuscitation. But equally, you don't want to give too much fluid. Just as Natasha said, it would dislodge the first clot, and first clot is the best clot. But equally, you want something to happen. So in the ideal world, you'd want to give blood products and use a massive hemorrhage protocol. And there is more and more data to support you do 1:1:1 ratio of blood FFP and platelets, if possible, whole fresh blood. But we use component blood products, and that's why a ratio of 1:1:1. And then warm blood products, because you don't want to make the coagulopathy worse by using cold blood products. Early tranexamic acid. And again, this is not based upon any pediatric evidence, but the evidence on the adult side is quite robust, with the fact that the negatives are fairly minimal, and that's why we feel quite safe and comfortable using more and more tranexamic acid, even to the point of using it in head injuries, unless your GCS is less than 3 or you've got fixed dilated pupils. So we use what I would call as a cautious resuscitation strategy rather than hypertensive resuscitation strategy. I'm trying to find a happy medium. And then, of course, you're looking at why the patient is in shock. If there is an obvious source of hemorrhage, you try and control it. But if there is not, most of the times it's bleeding in the abdomen. And then whether or not the patient needs damage control laparotomy, etc. So this, very briefly to say what damage control resuscitation is, and this again comes from the military background, where they realized that limited surgery to control bleeding and contamination, which means they're spending less time in exploring and trying to fully correct whatever the problem is. So less time in theater, rapid temporary closure means we have more time to create physiological stability before the patient goes back, had better outcomes. So this is what we use more or less in civilian practice as well, with ongoing resuscitation, gradually rewarming patients, transfusion, give time for the acid-base balance to correct before they go for a definitive repair or wound closure. So thankfully, we don't, majority of children have blunt abdominal injuries, and they do quite well with conservative management. It's not very frequent that they need an urgent damage control laparotomy, but when that happens, they would come back with an open abdomen. So they just go in, find a bleeder if there is none, pack the abdomen, bring the patient back, and then they go back to theatre for another look. Unless there's a bleeding spleen, which then needs to come out, etc. So this is what damage control resuscitation looks like. So tranexamic acid, rapid diagnosis, limit crystalloids, which is what we're doing more and more. I mean, we're limiting crystalloids even in non-trauma patients as well. Early 1:1:1 transfusion, permissive hypertension or cautious resuscitation with fluids, and rapid anatomical control is what it looks like. And these are just two recent papers using in one the tranexamic acid and no tranexamic acid, and you can see the mortality benefit. Again, adult data and the conventional component therapy and whole blood therapy. And that's why the proposition that we should use 1:1:1. So this is what is the NICE guidelines for pediatric shock. So those who have hemorrhagic shock and traumatic brain injury, so if the shock is dominant condition, restrictive volume resuscitation, or if TBI is the dominant condition, we actually try and aim for a higher normal blood pressure for these patients to maintain cerebral perfusion. This is our East of England protocol for massive blood loss. And I think it's probably time that we should update it. We haven't. It has very specific definitions, and I suppose it's very difficult to use these when you are in real life emergency, because you don't have time to define how much blood loss the child might have had. But basically, it's useful also for the teams who are not aware or kind of not that experienced in looking after these children, and gives a guidance. The good thing is, once you've activated a massive blood loss protocol, the calculation of how much blood and which product the patient needs is taken out of your hand, so you can focus on other things, and the blood bank decides, and they keep sending you first pack, second pack, which has all the required numbers of products that you might need in that situation. This was our own data again from East of England. We reviewed the blunt abdominal injuries, and out of over 5-year period, so out of 400 odd patients, nearly 1/4 had blunt abdominal injuries, and 10 were excluded because 3 were penetrating and 7 had incomplete data. And in the final analysis, as you can see, majority were non-operative management. The commonest organ injured spleen, followed by liver, kidney, and then pancreas. And out of the non-operative managements, a few then required later laparotomy for either a cyst or a abscess, endoscopy, and interventional radiology in 2 patients. So they do fairly well otherwise, if we can give them conservative management. But very, very important when we're talking about hemorrhagic shock is to remember this triad of coagulopathy, hypothermia, metabolic acidosis, which just makes it worse and worse. The coagulopathy gets worse, the acid-base balance gets worse, and the hemorrhage control becomes increasingly.
No, I'm just listening to Shruti talk, but I've heard it before, so I'm going to leave. Don't worry.
So
no, I'm coming now. I'm just going to step out of the room to talk to you because I've just got to cue you up about this kid.
So there's, of course, a major emphasis on minimizing ongoing heat loss. And I know it's important in adults with trauma as well. It is probably 100 times more important for a child because they've got large surface area. The physiology is such that they tend to lose heat more rapidly. The homeostatic mechanisms are not so well established and mature. And this is just to highlight, like, how the thermoneutral zone would vary between, for example, an adult and a preterm infant. So we have to be fairly aggressive. And especially we live in the UK. So if the patient spent any time at the scene of accident, they're very likely to be cold. So always check temperature, warm fluids, if possible, warm blankets for transfer. And then, of course, we're looking at the splinting and adequate pain relief. Of course, this is just the same like we would use in any other patient with an important introduction of pupils. Hopefully we do that in a non-trauma shock as well, but clearly very important because majority of our patients would have brain injury. So to look at pupils and blood sugar. I know I've been going on for nearly an hour, so maybe I'll finish this and then I'll stop. So, once we've done the early stabilization, the key now to define what happens to the patient, how we treat, is to know what injuries the patient has. And the only way we can know is by doing some form of radiological imaging. So in a trauma situation, CT and X-ray are the 2 imaging modalities. They practically no role for ultrasound or MRI in an acute setting. But in the pediatric population, it's very, very important to know that we do not advocate a whole body CT like we would use in adults to image children, because children have different injury patterns. As well as I said, we do not see that many great vessel and cardiac injuries. So that means, and the chest trauma is mainly pulmonary contusions. So what we have not picked up on chest X-ray is highly unlikely to be life-threatening, which would only be picked up on CT. So what is being advocated nationally for the last 8-9 years is focused imaging, depending upon the area we feel is injured. And the biggest reason for doing that is children have radiosensitive developing tissues, and their lifetime cumulative risk of developing a malignancy from radiation exposure is much greater than that for an adult. So we try to minimize that risk. So these pediatric trauma protocols are under revision right now. Not much has changed, but what has changed is that they've now included chest X-ray as a part of primary survey. And if the chest X-ray is fine, we should not be doing anything else. So these are the reasons, as I said, different injury patterns, rare spinal and pelvic injuries, liver and splenic injuries are usually treated conservatively, and the cancer risk is much greater. So this is a little diagram we have created here in East of England. You'll find them in Tempo Manual. This is available online. You also have an app to download it. And basically, this is just, we've introduced the radiation exposure risk from each imaging modality so that we consider we're not overexposing the patient. And essentially, the criteria for head injury imaging is NICE head injury criteria. If you're doing a CT head, the patient gets 1 year worth of radiation exposure. If we do CT C spine, it's no, he's just talking on the phone with somebody. So between CT C spine and C spine X-rays, look at the difference in the radiation exposure. So, and that depends on, it's 1 to 3 years because it depends upon the scanner, what protocols they're using, etc. So it's not very straightforward while it's only 1 to 2 weeks for X-rays as well as for CT chest. It's 3.6 years in comparison to 3 days. And the multiple audits, including our own audit, which showed that there were only 3 extra injuries which the CT chest picked up, which were not picked up on chest X-ray, but none of them were life-threatening. So a small apical pneumothorax, I know I'm not going to drain. So it doesn't make a huge difference, even if I picked it up. So this is just to highlight, and we've kind of been running a quality improvement project to try and highlight why it is important so that it's educational, people forget. And when I'm in an emergency, I reflexly do what I'm used to doing, which is like, do a head-to-toe CT, and that kind of brings a level of reassurance as well to know that there is no further injury. But then equally, if we can highlight how this could have long-term impact, it's useful. Sorry, I have too many slides and I can keep going, but I will stop